All right. We're live now. We'll just give it a few more minutes for people to join.
See ya. I should be able to see the chats that they write as well, but I'll just use yours as. She's pretty active right now, so I'm gonna actually just while we're waiting, I'm gonna just take her downstairs. All right.
All right, sounds good.
Give me 2 minutes.
Mm-hmm.
You all of a sudden got active. All right, come on. The baby's downstairs. I see a lot of questions. Is there a way to like poll the audience right now and ask them like how many of you are pre-med versus like med school?
You can just ask it live, and they'll just answer in the chat. So, you guys
Just
heard
because
Dr.
like just so I know like
Mm-hmm.
my audience in the sense of
Mm-hmm.
different levels of jargon, for example, or medical terminology will be used, obviously. So I want to make sure that everyone understands. But I'll keep it as basic as I can because maybe some pre-med in here versus med.
Mm-hmm. Yeah. So, you guys go ahead and put in the chat if you're pre-med, med, or even high school. If you're in high school, just put that in the chat.
Whatever level you guys are.
Mm-hmm. All right. It's 7:05 and people are starting to come in. So I guess we can get started. Hello, everyone. Welcome back to My Medical Message. Thanks for joining today. Today we have Dr. Hassan Patail, and he's a pulmonary critical care faculty attending. And he's here and has prepared a great presentation for y'all. So welcome.
Thank you for the introduction. Thank you for having me. I appreciate everybody who's joining. We're going to try to make this as interactive as possible, so please continue to ask questions throughout. Um, I don't like to just read off the slides. I like to get kind of what's your guys' opinions and concerns and questions as they come. I know there may be a lot of you, so that may be difficult at times, but let's get through it. So, um, my name is Hassan Patail. I'm an assistant professor, pulmonary critical care faculty attending at a hospital in New York City. Um, you guys can Google, and I'm sure you'll find where I work. But anyways, so my field, so pulmonary. I've been asked to obviously talk about my field. My field is in kind of two parts. It's pulmonary and critical care, and that's pretty much combined. All right, so I'm a specialist. Pulmonary goes with lungs. I'm a specialist in lung pathologies. Some of those lung pathologies are chronic obstructive pulmonary disease, asthma, interstitial lung disease, pulmonary hypertension, lung infections, all lung infections, but an example would be pneumonia, lung cancer, which we do procedures to diagnose lung cancer. Um, and that's mainly the pulmonary. I mean, there's much more, but that's the gist of it. That you're treating those type of disease processes. And critical care is just like the word, just like it says, critical care. It's if you're in med school or if you're above, you'll know that what internal medicine is kind of like. It's basically super internal medicine, or I like to call medicine junkie, which means that you have to know all the organ systems in the entire body to be a critical care attending or a critical care physician in general. Because when your patients are come in very sick in the intensive care unit, most of the time, multiple organs are not functioning, and we have to correct each and every organ to the limits that we can while they're in the intensive care unit. And then we call certain specialists at the time, like cardiologists, GI doctors, etc., if those patients need procedures for those organs. Um, we must know how to use a ventilator. I'm sure all of you guys know what a ventilator is, especially now during the COVID pandemic. Being a critical care physician, you have to know bedside procedures, many bedside procedures, such as central venous access, chest tubes, endotracheal intubation, percutaneous tracheostomy, and etc. So many bedside procedures, and these bedside procedures are not really done by the general physician or GI doctors or sometimes cardiologists or nephrologists. It just, we kind of do the main type of bedside procedures. General medicine does some. Every specialty has their own procedures, but we kind of do the general, multiple different bedside procedures. And then we have to really know bedside ultrasound to be able to manage and diagnose patients in the critical care unit, and for other organs as well. For pulmonary, cardio, you have to know how to use bedside ultrasound. So we kind of have to know a little bit of everything, plus our main organ, which is the lungs. So should I just answer some questions, I guess, while we're going, or right? Right. So okay, so I'm gonna use because there's a lot of questions on the YouTube, so I'm gonna use your questions right now in the chat first. All right. So how many years does it take to be a pulmonologist? It's gonna be at the end of my slides. How often do you work with cardiologists? Every day. When you're in the critical care unit, and even in not, when you're in a hospital setting, you're working with multiple disciplines from all types of fields. So you're always working with everybody. What new advancements and new technologies have been developed in the past few years that have improved how you do your work? How do you balance work and life? Do you cooperate with physicians of other specialties when making diagnosis? Yes to the last question. Work-life balance, I'll talk at the end as well. All right. COVID, how has COVID affected our work? So COVID has affected our work intensely and immensely past couple of years, especially in our field, because we are the ones who mainly manage the ventilators, and many COVID patients end up on ventilators, unfortunately. We also manage the high flow nasal cannulas, which is oxygen delivery system that puts oxygen in your body at a very high flow rate. Um, so we kind of are, I'm not going to take all the credit. With COVID, many other specialties have kind of picked up their care as well, and they've really helped the critical care attendings and the pulmonologists out as much as they can, and they've also managed multiple units when multiple hospitals are opening units to increase capacity. Other specialties have to step up, and they really have. So it's affected our work. The pandemic obviously is not over. We still have sick patients every day with COVID coming in. We still have sick patients dying every day. Unfortunately, there's a lot of good in my specialty, but my specialty also deals with the sickest patients in the hospital. And dealing with the sickest patients in the hospital, unfortunately, we see a lot of death as well. So it's kind of like you have to be ready for that if you want to kind of do this specialty. All right, so I spoke about my field a little bit. I'll answer some more questions in a bit. So the work hours of my field depends on what type of system you work in, really. The academic setting versus semi-academic versus private is very different. I work in a more kind of an academic setting, at a decently decently sized hospital. So, when you work, I won't really speak about private practice because that's not really what I do, nor, I don't like to speak about things that I don't know about. So, what I do is I basically do one service block a month, which is on average. A service block is usually a week span. You work, usually 8 to 6, 7 to 5, something like that. It just depends on what institution you're at, but it's a full day, Monday through Friday, and usually that's if you're on the consult service. If you're not on the consult service, since we manage the MICUs or the medical intensive care unit, that's usually 7 straight days, weekends as well. So, and that's usually 12-hour shifts. And then when you're not doing that, your other rest of your days are kind of scattered. It depends again on the institution you're on. It's you're doing research, you're doing education for residents, fellows. There are med students in there, but definitely med students. You're doing some administrative time, or you're working nights. If at certain institutions there are nights, certain institutions there's no nights. So it just depends. So it's very hard to say what work hours if you go in this field, what you will be um, shown or what you will have to do. It just depends on where you go. Private practice is very different. Private practices, you know, um, it just kind of depends. So what I would recommend is if you do one day become a pulmonologist or a doctor, and whatever field you go into, and when you start getting to the point of interviewing for your actual jobs, even though you think you like academics or you think you like private practice, interview at all the different types of places so you kind of get a feel of what you may or may not want out of life, because the lifestyle is very different for each and every one. Um, that being said, each and every one, each type of institution you work at, you can still kind of figure out your hours, still kind of like make your schedule, still kind of like, it's easier than, school. It's easier than med school. It's easier than residency and fellowship in terms of schedule, because you kind of make your own schedule in sort of sense. So the most interesting part of my job, in my opinion, is I take care of the sickest patients in the hospital, and that comes with, you feel good about it that I am the doctor when other doctors are not capable of taking care of them. I take care of them, so that in itself is rewarding that I get to take care of the sickest patients. And obviously, if we're able to fix or save or get the sickest patients better, that's a really great feeling. On the other spectrum, obviously, like I said, our field is very intense, very sick patients, and many patients die. And you have to be able to cope with that. You have to be able to kind of mentally be strong, so to speak, in regards to death, because we do see a lot of it, especially with COVID times. We saw a lot, and it's just something that you have to be able to accept, and you have to kind of deal with that process. Again, like I said, we have to know all the organs in the body, along with our own organ, which is the lungs. I have to know about the kidneys, and then I have to. If I don't know, there's a level to knowing as much as you can, and then obviously, if you need more help, you call the specialist, like the nephrologist, to help you out. Same thing with the cardiologist. There's a level that we know, pretty well, And then, if we need a patient to get, a PCI or a stent or a cath or a valve, that's when we call the cardiologist for help. Or even, with general heart failure, sometimes where it's difficult to manage, we call the cardiologist. So it's a very multidisciplinary in the ICU, and that's what I like about it. Again, and I'm trained to do many procedures that many other physicians are not, like bronchoscopy, ultrasound, um, and so forth. There's just a picture. If you, some of you are in high school, I see some of you are maybe even younger. This is just a very basic schematic of a ventilator. Obviously, you have air and pressure going into one circuit, and then it's going into the patient's body. It's giving positive pressure into the patient's lungs. It's inflating the patient's lungs, and the patient exhales, and it comes back out of the circuit and goes back to the ventilator. We use the ventilator, for respiratory diseases, for patients who can't breathe on their own. Sometimes, before COVID, the ventilator was something that we used quite often, but we knew that most likely we can get this patient off the ventilator in a few days to maybe a week. Not all the time, but most of the time. Now with COVID, now we're very reluctant to use ventilators because we know, patients with COVID pneumonia do very poorly on the ventilator. Most of them do poorly. You hope for getting them off the ventilator, but these days it's very hard. So a lot of COVID patients, when they get on the ventilator, sometimes they get trached, which is which is basically you move the vent from the mouth to the neck, and there's a hole that's created, and a tracheostomy is created, and then the vent can be connected to your neck, and then you kind of start your rehab to get better. Or unfortunately, many patients, when they get severe COVID and they end up on a ventilator, many of them pass. So we kind of deal with the ventilator every day, and even in other units in the hospital. For example, many cardiac care units, when patients go on a ventilator, they call us as consultants to help them manage patients on the ventilator. That happens also in ICUs all around. So because and that's why pulmonary and critical care both go together, because pulmonary is the lungs and the ventilator goes in the lungs. So it kind of goes hand in hand. That being said, other specialties do know how to use ventilators if they're critical care trained. So let's just do some more questions over here. What does a day in general pulmonology look like? I kind of answered that. What are some of the most common procedures? I kind of said that. Let's see. What made me choose pulmonology over other specialties? To be honest, when I was a med student, and when you're in your career for medicine, never just latch onto one thing. Get a little taste of everything, and then make your decision once you've got experience with every field. When I was a med student, I thought I would really like GI, and I was like a gunner when it came to the GI rotations, and they, I wanted it. And once I got to residency, I realized I did not like it as much. And then, I thought I liked cardio, and I do like cardio, but something just kind of didn't really click where I was like, nah, I don't really know if I really like this. And then I did my in residency the first year. I did my rotations. Obviously, everyone has to do ICU rotations, and once I started doing my ICU rotations, and again, seeing that they were managing the sickest patients, and I just really liked it. And the fortunate or unfortunate thing about medicine is kind of it's very center and attending dependent. So in your training, if you have a really good mentor that's GI, you're going to just be attracted to GI. If you have a really good mentor or a very intelligent pulmonary critical care doctor, which I had, there were just really smart attendings at my program for pulmonary critical care. And I was like, man, I want to be like them. So you kind of get attached to that type of field, any field. So it just kind of, it's very attending and center dependent. Some places, some students, for example, I hear they go do like an OBGYN rotation, for example, and they wanted OBGYN their whole life, but they have a terrible experience in that rotation. They get turned off by it, and that's what kind of stinks, where we don't have enough time to continue to do the rotation to see if we really like it. You're pushed from one rotation to another. So the fact that you guys are all on this video chat also makes it good. Like, keep doing these type of things to continue getting exposure to different people, different fields, and see how you like it. Just what inspired me. Someone asked what made you general pulmonologist, but also assistant professor. So, when you work in the academic setting and when you work for an institution that's associated with a medical school, um, then there's like professorships, right? So not that I don't sit there in class, like in med school classes and teach and lecture. It's just a title that you get in academia. And it starts. I'm a newer attending. I'm in my first couple of years of as an attending. I finished fellowship last year. Um, uh, so, you start off usually as clinical instructor or assistant professor, depending on where you go, and you have to kind of raise your ranks as you're in academia by publishing research, by publishing papers, by giving talks like this, for example, or grand rounds or Zoom grand rounds, or before the pandemic, people would go to other institutions and give these type of talks, not necessarily about what my job is, but I would go to another institution, for example, and talk about pulmonary hypertension because I'm an expert at that, and tell the other hospital that, oh, I do this, this, and this for pulmonary hypertension, and I've gone away from this, this, and this. So you kind of raise your ranks by giving talks, teaching medical students, teaching residents, and doing research. So clinical instructor, assistant professor, then it goes to associate professor. And again, this takes years to go up, and then you become a professor, and that's like the higher rank of academia. Um, all right, let's see. Hold on, I'm trying to use my mouse. So someone has a good question. Has there been more asthma and bronchitis cases due to increased cases of COVID? So, and at the beginning of the pandemic, actually, the asthma, COPD, bronchitis, we weren't really seeing those patients in the hospital. For whatever reason, it was kind of unknown at the time. It's still fairly unknown. Could it be because those patients take steroids, consistently, and they have some sort of immunity? Unknown. But basically, the main person who gets affected, everyone gets affected from with COVID, age, um, male or female, different weights, different obesity criteria with BMI. They all get affected, but certain people get affected more with COVID, and certain people do poorly. So you're more likely to do poor if you're male, if you're elder, and you're obese, and with diabetes. Like those are like very common things. If you have that that quadruple, those four things, like you're more likely to do poorly. It doesn't mean you're going to do poor, but you're more likely to do poor. So you have to kind of take um, caution when you see those patients. Obese patients do poorly with when they get COVID pneumonia, just because obese patients have difficulty breathing already because their extrathoracic pressures, the pressures in their chest, are already very high. So when you add COVID to the system, you have a very hard time taking big breaths and oxygenating. So those are the people who do worse with COVID. All right, let's see what else we got. Answer one more question, then we'll move on. All right, so when I'm on call, what kind of patients are typically called for? So when I'm on call, it's usually, so we do pulmonary call, which is just like 9 to 5 pulmonary, which is you're going to get called from hospitalists or general medicine or other specialties about lung pathologies, COPD, asthma, bronchitis, sometimes pneumonia. And those we just assist the primary team on how to manage those patients. We write notes, we tell them, hey, we should do this and this. And then sometimes they'll call us for bedside procedures, like if a patient has a pleural effusion, they'll ask us maybe to drain it, or does it need to be drained? So they'll ask us questions like that. Now, when I'm on night call is more, and even day call. When you're on day call and we're doing critical care consults, anytime a patient is quote unquote crashing or decompensating or looking more and more sick throughout the day or the week, they'll call us and say, does this patient need to be in a step down unit or an ICU? And that's our job to decide that if they need to be in those areas of the hospital. So, we deal with the sickest patients. So when those patients are quote unquote crashing, we have to decide, does this patient need to come to the ICU? So that's what we see. All right, let's kind of move on. So cases, that is perfect segue. So cases I see. So we're gonna do a case real quick, and you guys are gonna kind of ask questions as we go. So I'm gonna just read it. 65-year-old male with hypertension, diabetes, obesity presents with acute onset of shortness of breath, cough, and fatigue. Family member was sick recently with similar symptoms. In the ER, found to have a temperature of 101.2, tachycardia to the 110s, respiratory rate of 28. Pulse oximeter shows 85% on room air. Physical exam is awake, alert, toxic, fatigued, and mild distress. I think I spelled distress wrong. Mild distress due to, sorry, I can't see my slides. Hold on. Mild distress due to tachypnea, scattered rhonchi on bilateral hemithorax on auscultation. Heart sounds are normal besides tachycardia, abdomen soft, non-tender, non-distended, no edema in the peripheries. On 100% non-rebreather, patient's pulse oximetry improves to 95% with some improvement in respiratory rate as well. Labs, WBC count of 2,000 with lymphopenia, hemoglobin and platelets within normal limits, electrolytes are within normal limits, CRP is 100, D-dimer 600, ferritin 1,000, INR is within normal limits. This is the chest x-ray, all right? So with the chest x-ray, I'll just kind of show you what's going on. I'm gonna keep it again basic because we have high schoolers in here. This is a plain film chest x-ray. This is the right lung, this is the left lung, this is the heart, all right, this border. This is the airway. This is the right main stem airway. This is the left main stem airway. And this kind of rectangle, if you just trace my lines down here, can you guys see my mouse move, by the way? Okay, you guys can. So this is the mediastinum. What you see is kind of interstitial, peripheral, patchy opacities, some dense opacities in the left lower lobe. So you don't have to be a genius to know what's going on, but somebody in the chat, I'm just going to scroll down to the very end of the chat. What's your assessment and plan for those of you who are in med school? You don't have to be a genius to figure this one out.
So actually there's sometimes a little bit of a delay, so they might be hearing you just a bit late.
Okay. I'll wait for
a
minute or so.
Mhm.
All right, no worries. It's probably still delayed, so I'll just continue so we don't just sit blank. So this case assessment this is a 65-year-old male, most likely we don't have the COVID test yet, but most likely with COVID pneumonia right now. That's the number one diagnosis in the times of today. And you would say this patient has acute hypoxemic respiratory failure secondary to COVID pneumonia. Plan for this patient. Right now, what we're doing for COVID pneumonia, obviously give them oxygen. So the non-rebreather mask worked, brought the oxygen saturation up, decreased the patient's tachypnea a little bit. We'll give the patient steroids. We'll give the patients remdesivir. Remdesivir is really the only FDA drug approved. So steroids are also approved, but everything else that we do is kind of off-label / not FDA approved. So we do other things because we have to, because COVID is such a intense entity that still we haven't fully solved. So so you give them non-rebreather. Sometimes you have to give them high flow nasal cannula, which is even more oxygen, same oxygen, but it's going in at a faster flow rate. Or last but not least, if you have to, then you put them on a ventilator, but you really try to kind of not postpone, but you try to do everything in your power prior to saying that I've done everything in my power to try to get this person better, and the vent is the last resort at this point. All right. So I didn't write differential diagnosis, but there's a differential diagnosis in all this. It just could be any other viral pneumonia as well. All right, just to know that. Before COVID, there was RSV, there was metapneumovirus, there was flu. We don't really see those these days that much, and most likely it's because we were wearing masks, and people are protecting themselves. Unfortunately, COVID is much more effective, and that's why we're seeing it. So continue to wear your mask, whoever's out there, even if you've been vaccinated. All right, case 2 is a very common thing that we see in the ICU as well. All right, so 75-year-old female with congestive heart failure, ejection fraction of 35%, hypertension, diabetes, ESRD, and stage renal disease on hemodialysis, presents from nursing home with fevers, chills, altered mental status. In the ER, found to be tachycardic to 135, respiratory rate of 14, blood pressure 70/40, saturating 100% on room air. Physical exam shows the female in no apparent distress, but eyes are closed, non-responsive to verbal stimuli, but does move extremities and makes incoherent sounds on tactile stimuli. Clear lungs, tachycardia irregular, S3 gallop, 2 plus spinning edema in the lower extremities. POCUS, point of care ultrasound, dilated LV shows a dilated left ventricle with severe decrease in left ventricular function. IVC is large, 2 centimeters, and non-collapsible. Labs are significant for a WBC count, white blood cell count of 20, hemoglobin within normal limits, platelets 500, BUN 80, creatinine 6, and a pro-BNP of 8,000. Chest X-ray is similar to the last case. All right, it's actually the same chest X-ray I put up, but I just want you to show that different diseases can present similarly sometimes in certain workup. And this is the peristernal long axis view, echo view of the point of care ultrasound. So I'm just going to play it for you. All right. So here you have just point out the left ventricle, the right ventricle, the aortic valve, the mitral valve. This is the anterior leaflet of the mitral valve. This is the left atrium. All right. And what you see is a very low systolic function of this left ventricle. It should be squeezing in and out. This anterior leaf of the mitral valve should be coming close to the septal wall. And that's how you know the heart is working properly. This heart, unfortunately, is not working as properly as it should. The X-ray is the same X-ray, like I said, interstitial process, which could be, this could be fluid overload as well. All right. So assessment and plan, I'll just talk to you about it. So this lady is 75-year-old female with congestive heart failure with known low ejection fraction. Comes in most likely in septic shock. Not, we can't really say it's shock yet because I didn't tell you that we given fluid and it didn't work, but let's just say we gave fluid, it didn't work, and her blood pressure is still low, so she'd be in septic shock. And let's just say most elderly females from a nursing home most likely go into septic shock because of urinary tract infections. All right, so is this cardiogenic shock? Now, I didn't tell you if the patient's peripheries were cold or warm, but let's just say most likely this patient's peripheries are warm. Most likely not cardiogenic shock, even though the heart looks very non-functioning or low function. That's because she's known to have a low cardiac function. She's still perfusing a bit, but more likely it's septic shock. And it needs to be treated with antibiotics, and it needs to be treated with pressors, which are medications to increase the blood pressure after fluid resuscitation has been given. Though this patient, we wouldn't really give fluid resuscitation on off the bat because we know that she's a dialysis patient, and she tends to keep water in, and she has no way to get the water out. Plus, she's a heart failure patient. So, very common thing we see. Obviously, you have to kind of look head to toe and see what's really going on. And one thing with critical care is, you have to be very sure of what you're managing, because if you treat the patient incorrectly, this patient has a very high chance of dying, just like the first patient. So everything you do has to be meticulous. Everything you order has to be proper. Everything you treat with has to be thought of the risks and benefits. And most patients in the critical care units are tenuous in terms of if they're gonna make it or not. They say there's data out there that show that even if you just walk into the critical care unit, there is around it varies, but 20 to 30% chance of dying just with normal kind of organs. Obviously, when you have organs that are failing, you have more and more chance as organs are to continue to fail or are not as working as well as maybe a 30-year-old's organs. All right. So we'll do some more questions. So there's some private practice questions. Again, I won't really answer those because I'm not in private practice. So how do I stay positive and maintain overall physical, mental health? That's a good question. Again, because I told you my field is very intense, very tenuous, very, we see death a lot. You just have to be, like I said, you have to be prepared for it. And you have to, I don't like using stereotypes. And, a lot of times, my last slide will tell you this, like there's a lot of stereotypes in medicine in terms of should I be a doctor or not. I don't want you guys to ever think of those stereotypes and make you sway away from being a doctor. There are stereotypes, however, kind of in different fields of medicine, which, stereotype is not a real thing, but there's a type of person that's meant for every field. We'll use that, right? There's a type of person who fits into every field, and there's a type of person who doesn't fit into certain fields. Like I am a very kind of type A personality, on the go, like to, I don't like to sit for too long. I have a lot of energy, so, and I know, and I have ways that I'm able to cope with my own mental and physical health, right? And so this field, though it's taxing, I'm able to manage it because of those things, right? I still go to the gym. I have a great wife. I have a good family support. I have good friends, right? Like, and I've always been able to talk things through. And create a good environment wherever I'm at. So for me, I'm able to cope with it. Now, if there's another person who, is, and I still, when I talk to families and when I tell families that, your patient, your family member is going to die, because we have to have those conversations. If that family member starts crying, I tear up still to this day. So I'm not immune to, being sad. Or anything like that. I just figured out ways to kind of cope with it. But there's certain other people who may not be able to do it, or just can't handle that type of intense environment, where that's totally normal. That's totally fine, and that's why it's the field is for certain people, and it's not for certain people as well. I chose that I wanted to be a specialist, and I wanted to be kind of this type of specialist, so that's what I did. Again, there's also there's a type of person who fits in the emergency room. There's a type of person who fits as a cardiologist. There's a type of person who fits as a dermatologist. Everyone has their own kind of sense of who they are, and every specialty has not a really a stereotype, but a type of mold that uh, doctors kind of either already have or end up fitting to based on that specialty. What made me choose internal medicine at the time before residency? It's a good question. So as a med student, I liked surgery because again, it's like, I felt like the surgeons were like the bosses in the hospital, right? They just like walked around with a swagger, and it's just like I said, everyone has a mold, right? But then I realized that I just didn't like the OR that much. Like I like procedures, I like bedside procedures, but I don't like standing for 5, 6 hours doing a case. Like it just wasn't my thing. That and I just at the time, I could be wrong, I felt like surgeons were not operating as much as they once did like 20 years ago. So for those reasons, and I really liked, I liked rounds. A lot of people, some people hate rounds. Some people think rounds are boring. Some people think rounds are unnecessary. But you have to like rounds for internal medicine. You have to sit there and stand, and we're not operating for 4 hours, but you may be sitting and talking about a patient and management for 4 hours. Um, so that's kind of, I just like thinking about the patient more, thinking about all the entities, all the different organs. And, I told myself like, if my family member were to get sick, and this is no knock on any physician at all, everyone has their own specialty, everyone has their own training, everyone has their line that they're good at. I felt that internal medicine was best equipped for if my family member got sick with some sort of disease, God forbid, and they came to me and said, "Hey, like, what do I do?" I felt like internal medicine was the most broad to let me answer that question and take care of family members who one day get sick. Obviously, I'm not a surgeon, so if my family member ever got and needed surgery, I would tell them about the medicine aspect, and I would call one of my surgeon friends and say, "Hey, my family member has X, Y, and Z. Does they need surgery? Do they not?" So that's how I looked at it. Uh, So can you elaborate on what a differential diagnosis is? So you'll have to, as you go through medical school, and residency, every time you see a patient, for example, let's just say hypoxemia, low oxygen levels, right? Your differential diagnosis at that moment has to be, why is this patient hypoxemic? Why is this patient have low oxygen levels? And at that moment, you're different in your head. Your differential diagnosis has to just run 1, 2, 3, 4, 5, 6, 7, right? Or even more, right? All the causes of hypoxemia should hit your brain at that time, right? Pneumonia, hypoventilation, um, large pleural effusions, pulmonary embolisms, high altitude, for example, right? So those differentials have to just go in your head, and that's just not for hypoxemia. That's for every disease process. Bacteremia, right? Why is this patient bacteremic? So that's what a differential diagnosis means, where you have a set of different diagnoses that could cause this picture that the patient presented with. So the patient presented with these symptoms, my differential diagnosis is X, Y, and Z, and I have to do the workup, right? Labs, imaging, bedside ultrasound to narrow my differential diagnosis. Also, I have to take a good history if there is a person's awake and alert. Now, in critical care, a lot of times the patient's not awake and alert. So history taking is a little tricky. If that's family, you have to look at you have to look at the EMS report or the ambulance report on what exactly happened. And with the history, with the physical, with the labs, you have to develop your differential diagnosis and have certain diagnoses where you have, oh, this is most likely COVID, for example. But just because you think it's COVID, you can't rule out, you have to still rule out other entities if they make sense. You don't want to reach and grab on one thing and just say this is that, that's over. That's bad medicine. Um, if you think it's a pulmonary embolism, right, you have to work it up. If it's negative, then you have to think of other things that are causing this patient to be hypoxemic. So that's what a differential diagnosis is. And start that from the basis of medical school. When you see your questions, your multiple choice questions, that's the whole point of multiple choice questions, right? When you read your multiple choice questions in med school, all the diagnoses, right, like A, B, C, D, are all kind of like, oh, they all cause that. So you have to go back into the STEM and figure out, okay, the patient's, D dimer is negative, can't be a PE or pulmonary embolism. Let's cross that out, right? So it's the same thing of your multiple choice questions. It's just live and in front of you at that time, and you have to make a quick decision. All right. Let's kind of keep going. All right, so we did that. So let's talk about how to get where I'm at, since we have about maybe 15 minutes left. How to get where I'm at. So obviously, 4 years of medical, you have to go. I mean, you technically have to go to college if you want to go to a U.S. med school. But let's say you want to go to foreign med school. Sometimes you don't have to go to college. You just have to go straight from high school. But you're usually med school in another country will attach 2, possible 3 years to make up for that university. It's kind of like pre-med you'll have to do at the university. But usually 4 years of college, but I didn't write that. But 4 years of college, 4 years of medical school, 3 years of residency if you want to do internal medicine, which is what I did, right? Now you can do, remember I said pulmonary and critical care are one entity, but they are also separate entities if you want them to be, right? So you can do critical care and not be a pulmonologist, for example. If you do ER, right? ER sometimes is 3-year program, 4-year program. If you do ER and if you want to do critical care after, you can do that. It's either 1 to 2 years after your ER residency. Surgery, or specifically trauma surgery, something most of the time, they can do critical care. They do 1 or 2 years extra after the trauma surgery. If you're a neurologist, you do your neuro residency, you can go into critical care after. It's usually 1 to 2 years, depending on where you go to be critical care certified. Nephro, renal, etc. So nowadays, you can add on, people can just do after internal medicine. They can just do critical care as well, where they do 1 to 2 years of critical care, and they're just kind of critical care intensivists. The job market is this is just a little bit more advanced, but the job market for each and every one is a little different depending on where you go. When I was training or when I was deciding, people told me like pulmonary critical care, it has more job opportunities than, for example, neurocritical care. Is that 100% true? Probably not. It just all depends on the hospital, the place, and the time you're actually looking. It just depends. Right now, you can be any critical care you want, and the job market is easy because of COVID. Everybody needs to staff their ICUs. So you can be any critical care physician you really want to be. You can also do pulmonary by itself and not do critical care. That's like probably 2 years, I think, after internal medicine, but it's not really common. Some people do it though. I have seen it where they're not really, intense. They don't want to be in the ICU. They just want to do straight pulmonary, which is consults and outpatient work, which is, that's totally fine if that's what you're into. If you really like the lungs, if you really like COPD, asthma, lung cancer, those type of things, but you don't really want the intensive care unit, you could definitely do that. So me personally, I did the 3 years of residency, and then I did another 3 years of pulmonary critical care fellowship. Now, and you can even do more than that if you want to do advanced or interventional pulmonary, which is another year, which is just mainly you do bronchoscopies and you do advanced bronchoscopy. Same thing, cardiologists, you do usually 3 years. And if you want to do interventional cardiology, you do another 1 to 2 years on top of that, where you're putting in stents, where you're putting in valves. So it all depends. Um, All right. Advice going forward. I think overall, don't listen to so much noise out there. Everyone has an opinion. Obviously, you have to listen to certain people's opinions who you trust, who will guide you the right path. But never listen to like negativity that people say, like, "Oh, don't do this, don't do that." Like, if you really love something and if you really want to do it, just do it. Right? If it makes you feel good inside, if it makes you feel like accomplished, if it makes you like want to really do it, like that's why I said I wanted GI, then cardio, and I was like, nope, pulmonary critical care is where it's at for me. Right? Granted, if you start speaking money wise, right? Generally speaking, GI doctors, cardiologists make more money than pulmonologists or pulmonary critical care people, right? That's like a base salary when you're looking at. But don't think about money, right? Just think about what you love, what you like, and the money one day will come. You can make in medicine in general, you can make as much or as little as you really want. That's the truth about it, right? If you work like crazy, which some people really like to do, you're gonna make decent money. If you want to work only 9 to 5, you can find a job that fits that lifestyle. So, and medicine, to get to where I'm at, the one thing, especially those in high school, medical school. So let's start high school first. High school, don't mess up in high school. Do well. Best thing to do is try to, get into college. And the one thing I'll say is treat college and any studying as a 9 to 5 job, right? I'll be honest, I didn't study that hard in college. Don't be like me. um, you know, be, take, do 9 to 5 as if it's your job, 9 to 5, and after 5 o'clock or after 6 o'clock, so whenever, then have fun, enjoy your time. And college is all about also having fun, doing experiences. So that's my kind of advice to you going forward. Treat it like a 9 to 5 job, study a little bit on the weekends, and, do well in college, because it's really, really, really hard these days to get into medical school. Every year it's harder and harder for the high schoolers out there, for the college kids out there. So, um, you know, life's all about balance. My dad always said there's a time and place for everything. There's a time to study. There's a time to party. There's a time to be spiritual. And as long as you can kind of make that time for each and every aspect of your life, you'll do okay. And medicine is all about evolving. The field continues to evolve. We must evolve with it, and that goes even outside of medicine. You as a person, as you get older, continue to get through your career and whatever you want to do. You should evolve. Don't be the same. Don't do the same thing as you did yesterday. Continue to be better. Continue to try to improve your life. Continue to try to educate yourself and others around you, um, and just keep moving forward. Don't look back. There's a lot of people that you're gonna outgrow in life. Especially with the high school students and the college students. Like, your friends are obviously your friends; they mean the world to you. But like, prioritize yourself first and your career first. That's what matters. And again, there are many stereotypes of medicine. Don't listen to really any of them, in the sense of when people give you negative advice, like, oh, don't be a doctor, just do this, just do that. No, if you want to be a doctor, be a doctor. If you want to do, a neurosurgery, right? Be a neurosurgeon. You'll figure it out. You'll do it. So overall, like, if you like healthcare, if you want to make a difference in people's lives, if you want to earn a stable salary throughout your career and be comfortable, then medicine is right for you. Work-life balance is easily achievable. People always ask, how do you, if you, I tag all my social media pages after this, but if you follow me on social media, I have fun all the time. I spend time with my family. I go out to dinners. Hang out with friends. Not so much these days because I have 2 young kids, but I do everything I possibly can to have fun and enjoy life. And at the same time, I work hard, and I work a lot, and I work a lot of hours, but I really love what I do. So that's what really matters. So questions, yeah, here are all my handles: IG, TikTok. Yes, I have a TikTok. Haha. Email if you want to email me personal questions. I'm usually, to be honest, if you really want to get a hold of me, I have an email that we check periodically. But if you want to like get a direct answer from me, Instagram is probably the best. And if you want to go to our website, we don't usually post that much stuff on our website these days, but we still have a couple good blogs that we wrote about, like residency, the joys of residency, fellowship, end of life. There's some good information on there. So if you want to just read it, go ahead. Um, so we'll just do some questions. We have 10 more minutes. Um, What was your first experience like when you lost your first patient? How did you react and deal with the situation? Um, it's tough. I mean, when you lose your first patient as a med student or as a resident, it's hard. Where it's like it's kind of like it's not even real at the first time. Where you're like, wow, like that patient just passed, and you're doing either chest compressions, you're helping run the code. It's tough, and I think that it's easier to swallow if it's an older patient, for example, if you know that they were on the way of passing or they have a terminal illness. But it's really tough. I'll just kind of go my experience when I lost as a resident a young female patient in her like 20s. That was really tough to swallow. She had a pretty bad disease process going on, but like you never, that was like tough, right? You have to like sit there and talk to the entire team after to kind of like decompress and kind of like just say what happened, what went wrong, what did we do? Did we do everything we possibly could? Speaking to that, um, speaking to that family was like the toughest thing where we were all just me as a resident, the fellow, the attending, we're all in tears. It's not that anything we did. It was hard to swallow because it just she passed, and it's still like I said, it's still difficult to this day. And in my field, like if you do it enough, and in any type of physician, you're going to see death. Um, there's a there's a method of handling it. There's a method of talking to patients. There's a method of talking to families. There's a method that kind of eases it all. Not that it makes it normal or okay, but it just eases it all. And there's a method of like um, making it humane, if that makes sense. You have to still like practice humanity 101. And the good physicians still are able to do that in the sense of talking to families, talking to their colleagues, explaining what's going on in jargon that people understand. So it's tough. It's a tough thing, but it comes with experience. um, Someone asked me if my daughter made an appearance yet. No, she did not. She actually is downstairs now. So I don't think she'll be making an appearance, but I appreciate the shout out. Um, this is a funny one. I've always been curious as to what kind of attending you are to med students. I know and sees if the residents, fellows, or med students know the answer, right? Um, Back in the day, I think that we've gone away from this now, at least in my generation, where it used to be if you got the question wrong, you get scolded, you get yelled at, you get in front of everybody. That usually doesn't occur anymore. It's more of a safe space these days in the hospital where we definitely still ask questions. I definitely, on my rounds, I'm consistently asking my residents, fellows, med students questions. And that's the only way to learn is active engagement. If you're just listening to me talk all day on rounds, you're not going to learn anything. But if I ask you a question, and let's say you get it wrong, you're probably not going to get it wrong if I ask that question to you tomorrow, right? Because you want to be good, you want to be smart, you want to know what you're talking about, you want to know, and that's what rounding and asking questions to your team is all about. And there's a respect to it. Obviously, you have to maintain a respect. Maybe back in the day, the respect wasn't as legit, but definitely in my generation, I treat all the med students, residents, fellows with utmost respect as my colleagues. And attendings you'll have, I'll give you advice. If you're MS3, MS4, starting to shadow, if you're a resident, you know you'll have your good attendings, you'll have your bad attendings, you'll have your nice attendings, you'll have your mean attendings, right? It's all about kind of conforming to what the attending likes, what the attending wants. But if anyone's actually mean to you, it's their problem, not yours. Just put it that way. It's their problem. Don't get down. Be bigger than the mean attending. Be bigger than the mean person, and just push the negativity away. All right. Looks like we. So, what is the most difficult type of procedure? There's a lot of different type of procedures. They're all difficult or easy in their own way. It just depends on experience, right? If you've done a million procedures in one type of procedure, you're going to be good at it. There's always, I like bedside procedures. I can intubate patients. I put in central lines. I do thoracentesis, paracentesis, bronchoscopy, um, everything. Right now, my experience, obviously, on most of them are very well. The more you do, the more you get better. So that's now those procedures can have complications, and when you have those complications, that's when you really know how to deal with those complications. If you're intubating someone and all of a sudden, their airway, their vocal cords close up, right? that's a problem where you have to be ready to deal with it. If you're putting in a central line in the internal jugular vein, right? If is the patient very big, the patient's neck is very short. Is their internal jugular vein collapsing every time you put the needle in, right? These are all issues that you come up with. Um, but you just kind of know how to get through them. And sometimes the procedures, sometimes it just depends. Sometimes the procedure will take 2 minutes, like boom, boom, you're done. Sometimes the procedure may take an hour. It just depends on the patient's body habits, the patient's diagnoses, the patient's compliance. Is the patient awake? Is the patient intubated? It all depends. So it's not really like one procedure is harder than the next. How do you deal with families or patients that have language barriers? You speak to them in their language. All hospitals have translator phones. Nowadays, your phone, all our cell phones have an app for translation that connects you directly to a translator. So anytime a patient is a family have a language barrier, try to, if your hospital has the resources, try to get a physical translator in the room, right? If it's Spanish speaking, if they have Spanish, a lot of hospitals have Spanish speaking translators or Creole speaking translators or French speaking translators, right? You can get them, call them like a day in advance and have like a long discussion in their native tongue. If you can't do that, get them on the phone. It's pretty easy. Um, what were some of the challenges I faced in med school? I didn't really finish this topic. I was talking about high schoolers and college kids doing well. I think you guys can hear my kids crying back there. But in med school, right, you have to succeed in med school. There may be some people in this chat or may listen to this that are not doing so well in med school or difficult getting through med school, right? You have to be able to sit down and study what I believe 8 to 10 hours a day. That's a fact. You can't really get around that, right? But there's such thing as quality over quantity. Your quality of studying has to be legit, and every person who studies will study a little different, right? The way I study may be completely different the way you studied, but you have to find out what works for you and then dedicate the 8 to 10 hours that works, right? You may be a flashcard person. You may be, nowadays I didn't have Anki or I didn't have, what's that YouTube that everyone watches? Sketchy. I didn't have that in med school. But I was like my own sketchy in my mind. I could have, I'm not saying I could have invented sketchy because I'm not an artist, but I didn't draw out things, but I wrote ways to remember everything. And that's what worked for me. And I wrote out all my notes, and I watched every lecture once. I wrote my notes down on a piece of paper. I turned every lecture into one 8.5 by 11 piece of paper, and I would throw my slides away, and I would only use those notes, and I would write on another piece of paper like, how do I remember this? How do I remember that? And I would just make mnemonics, and that's how I studied. But I studied 8 to 10 hours. So if you can find out if you can do the quantity plus the quality, you'll do fine in med school and you'll do fine on your boards. The boards, if you want to invite, if there's med students here, USMLE 1, right? It's a crazy test. You have to literally, unfortunately, you have to memorize the entire step one book, in my opinion. But along with memorization, you have to understand all the concept as well. Is it crazy? Yes. But is it doable? Yes, as well. Was it was it difficult to transition from undergrad to med school? It wasn't difficult. It was just a transition. And in medicine, you're going to have to transition every few years. So you go from undergrad to med school, completely different game, right? Then you're done with. Then you match. When you finish med school or you're about to finish med school, you match. Right? Residency is a whole different ballgame than med school. Completely different. Different just different responsibilities, different intelligence levels, different friends. Your friends are going to go into different matching or different specialties, match somewhere else, right? You have to make new friends, right? That's for 3 years. You're going to do residency. And then you're going to become like almost an expert at being a resident by the third year. And then let's say you go into fellowship. Fellowship, completely different ball game. Maybe you're now in a different state, different city, completely different. So you have to be able to transition each and every stage of your career and the career the stages there's it's kind of easy where it's set for you but it's kind of hard because every stage is completely different. You have to take a couple months to get used to. And as a fellow, when you walk in, you were a super resident as a third year resident, and all of a sudden now you're a fellow and you're a consultant and you're expected to know everything. And you're like, whoa, as a resident I wasn't expected to know all this, but now as a first day fellow I'm expected to know everything. So these are things that you have to just kind of get used to. So I think it's, are we at time?
Yeah. You can keep going if you'd like to. Otherwise we can stop right now.
I think we're good. I mean, I think if anybody wants to, now it's just a question and answer session. So I appreciate all the questions. I appreciate you guys having me on. I hope you guys learned something today. I hope you guys learned something every day.
Mhm.
And if you want to contact me, if you have more questions, here's all my contact information. And again, thank you guys for having me on and keep doing the good work that you guys do. And, for the future generations of medicine, I hope to see you guys soon. I hope to see you guys succeed. And I hope to maybe one day work with you guys.
All right. Thank you so much for being on my medical message and for all the lovely information, case studies, and everything that you gave us today. For everyone watching, we posted the Google Forms. Please fill that out if you want your shadowing hours. And obviously, you need 80% accuracy to get your shadowing hours. So make sure you're doing that. Again, thank you so much for being here, Dr. Patel.
We appreciate it. All right. Thank you so much. And enjoy the rest of the evening. And make sure everyone, like I said, last but not least, stay safe, wear your mask. If you're not vaccinated, get vaccinated. If your family's not vaccinated, tell your family to get vaccinated. We're still seeing, we're still seeing it a lot, and we're going back up in cases, what we're seeing in the hospital. So we want to kind of prevent another surge. So do what you can, educate. You guys are all pre-med meds, so you guys can also educate people on, what to do, how to do it in the sense of, pandemic and how to stay safe. All right. So stay safe, everybody.